And we are thrilled to have Erin Campbell today. We've been going back and forth for a while on figuring out how we could do this presentation for you, and it finally worked out. So I'll give you a little bit of background on Erin, and then we'll jump in. Erin's mother was primary caregiver up until, Erin was the primary caregiver for her mother up until her death from dementia with Lewy bodies, or DLB, in 2023. Her mother's difficult journey inspired her to pursue a midlife career change and go back to school to study dementia with the eventual goal of becoming a DLB researcher. Ms. Campbell is passionate about helping patients, caregivers, and the general public better understand dementia with Lewy bodies, as well as the ways in which those who are affected can be more acutely supported. She recognizes that DLB can be isolating and overwhelming for patients as well as for their caregivers and loved ones. And she owns Campbell Writing and Editing, LLC. And through that, she contracts with Dr. Andrea Bazzoki, who many of you have heard speak for us before. She's on the DANC board, and she's a neurologist at UNC. And Andrea and Erin have collaborated on several local educational DLB initiatives. Ms. Campbell has a master's degree in technical communication, is working toward completing a master's in applied neuroscience, and will begin her neuroscience PhD studies at NC State in August, so coming up quickly. So we are thrilled to have you all here. We do ask that you stay muted unless Erin asks you to unmute. We appreciate you joining us. And Erin, I will let you go ahead and jump in and take it away.
Okay, thank you so much. And I apologize, I had an internet issue, so I didn't hear the introduction. So if I repeat something you said, I apologize in advance. But hi, everyone. Thank you so much for this kind invite to present today. My name's Erin Campbell. I'll be talking about dementia with Lewy bodies, or DLB, and I'm hopeful that what I have to share will be helpful to all of you. I'm going to start by trying to share my slides. And can everyone see that okay?
Yes, we can see it.
Okay, wonderful. My connection to DLB, which Lisa probably shared, was that I was my mom's primary caregiver up until her death in 2023. Her difficult journey inspired me to attempt a midlife career change and go back to school to study dementia with the eventual goal of hopefully becoming a DLB researcher. So I'm currently a graduate student studying neuroscience. I realize that many people in attendance are quite familiar with DLB, whereas others are maybe just beginning to learn about it. So I tried to find a balance of providing some scientific background as well as practical resources for support group leaders, dementia ambassadors, patients, caregivers, and health professionals. So here is a brief overview of the topics that I will touch on. I'll start with a little background on the biology of DLB. Second, how DLB is typically diagnosed. Third, how DLB is treated. And finally, and perhaps most importantly, how and where patients and caregivers can find support, resources, and help. So what is DLB? First, it is a neurodegenerative disease classified as a synucleinopathy, which I will more clearly define in a few slides. Second, DLB is sometimes referred to as the second most common form of dementia that no one has ever heard of, because despite its prevalence, DLB is not particularly well known, and this is true even among some healthcare professionals. Third, DLB has a vast array of symptoms, and importantly, some of these symptoms are treatable. Fourth, antipsychotic medications are often contraindicated, meaning they can cause severe side effects. So knowing what medications a patient should avoid is really important. and I will go over these medications later in this presentation as well. Fifth, early and accurate diagnosis is the key to improve quality of life. As many of you may have experienced, DLB is a roller coaster. The symptoms can fluctuate dramatically, particularly in the early stages of the disease, which can make diagnosis quite challenging. Sixth, DLB has no known root cause. With other forms of dementia, like Alzheimer's, for example, there's an understanding that a combination of genetics and environmental factors might be involved. Researchers have identified familial patterns and genes of interest that increase someone's chances of developing Alzheimer's. But with DLB, we have been unable to find genes, familial patterns, or environmental triggers that are consistently associated with any sort of predictive risk. This is not to say that these factors do not exist, rather, we do not yet know what they are. Finally, DLB is a presentation of Lewy body disease, which is the umbrella term for several different disease presentations, which I will also elaborate on shortly. First, to provide some historical context, this gentleman, Dr. Frederick Lewy, is the researcher who discovered what he noted as inclusion bodies in the neurons of patients with Parkinson's symptoms in the year 1912. We now refer to these inclusion bodies as Lewy bodies. Dr. Lewy worked in Alois Alzheimer's laboratory, which is a name that most people likely recognize. When World War I started, he became a military medical officer for Germany, which was his native country. But because he was born Jewish, he fled Germany in the 1930s when the Nazi regime took over. He first escaped to London and later to the United States, where he became a citizen and served as a physician in the United States Army. Eventually, Dr. Lewy finished his medical tenure teaching at the University of Pennsylvania. Visuals and sometimes helpful. Here are two pictures of what Dr. Lewy first identified. These pictures show what a Lewy body actually looks like. The picture on the left is a real image taken under a microscope of the inside of a nerve cell. And as you can see, the Lewy body stands out from the rest of the cell in that it's very distinct in its structure and appearance. The picture on the right is a more simplified drawing, so it is a little bit easier to identify what you're looking at. The arrow indicates where the Lewy body is located, and the cell nucleus is identified in the picture as well. We just saw images of what Lewy bodies look like structurally, but what are they actually comprised of? Lewy bodies are caused by the buildup and consequent abnormal behavior of a protein called alpha-synuclein, which is pictured on the right-hand side of this slide. Alpha-synuclein is a neuronal protein that is found naturally in abundance in a healthy brain, as well as in the heart, peripheral muscles, and other tissues. The presence of alpha-synuclein is normal and not the problem. The problem starts when this protein begins to misfold and clump in an unchecked way. Lewy bodies are predominantly comprised of alpha-synuclein, but they also contain many more proteins. Research has focused on alpha-synuclein because it is the dominant protein presence in Lewy bodies. We don't understand what causes alpha-synuclein to misfold and clump. If we knew that, we would be much further ahead in the field of Lewy body research. The main role of alpha-synuclein is to control neurotransmitter release, so it is one of the many signaling mechanisms that allow neurons to communicate with each other. There are other diseases that can also be caused by the excessive aggregation of alpha-synuclein, such as multiple system atrophy. Any disease that is caused by excess clumping of alpha-synuclein is categorized as a synucleinopathy. When those synaptic connections go awry and Lewy bodies begin to form, these Lewy bodies can accumulate in different parts of the brain. And depending on where they settle, a person will be affected in various ways. Lewy bodies can begin their accumulation in any of the three areas of the brain highlighted on this slide, and then spread to other parts of the brain. If a person exhibits the symptoms listed underneath each of the three brain regions, then that is likely the part of their brain that is impacted by the Lewy bodies. So if Lewy bodies settle in the brainstem area, then symptoms such as movement, blood pressure, and sleep cycle control issues can develop. If they settle in the limbic parts of the brain, then emotion, mood, smell, and a person's sense of reality can be altered. Finally, if they settle in the cortical parts of the brain, then vision, cognitive tasks like attention regulation and judgment, as well as memory and language, are affected. This diagram displays the different presentations of Lewy body disease depending on where these Lewy bodies first begin to form. If Lewy bodies begin clumping in the parts of the brain responsible for cognition and emotion, then a person develops dementia with Lewy bodies. If the Lewy bodies first begin clumping in the parts of the brain responsible for movement, then a person develops Parkinson's disease. Both DLB and Parkinson's are progressive disorders, so these Lewy bodies can spread throughout the brain as the disease advances. Therefore, people with DLB can develop symptoms of Parkinson's if the Lewy bodies spread to the movement parts of the brain. And similarly, people with Parkinson's can develop dementia if the Lewy bodies spread to the parts of brain responsible for thinking. This latter scenario is typically labeled Parkinson's disease dementia because it starts as Parkinson's and then develops into dementia. So Lewy body disease is the umbrella term for Parkinson's disease dementia, and dementia with Lewy bodies. Since Alzheimer's is something that most people are familiar with, I thought it might be helpful to show the ways that DLB is different from Alzheimer's. As you look at this comparison table, please be mindful that these descriptions represent those who have DLB only and Alzheimer's only. In reality, as we will see on the next slide, people can have both pathologies. Autopsy studies have shown us that DLB and Alzheimer's frequently appear as co-pathologies. In people with both or other overlapping dementias, the symptoms will also overlap. So with this distinction in mind, the prevalence of Alzheimer's is much higher than DLB. But there is reason to believe that many diagnosed DLB and Alzheimer's patients, as well as likely many DLB patients who have been misdiagnosed with Alzheimer's. The underlying cause of DLB is unknown, whereas Alzheimer's is thought to be caused by a combination of specific genes, as well as a variety of environmental and lifestyle triggers. Both DLB and Alzheimer's are caused by abnormal protein folding in the brain, but these culprit proteins are different. In Lewy body disease, the protein that misfolds is alpha-synuclein, whereas in Alzheimer's, the proteins that misfold are beta amyloid and tau. As for cognition, what I would like to highlight is that DLB is not so much about memory loss, whereas Alzheimer's definitely is. This is not to say that someone with DLB will not experience memory loss, because some people do. But in those with DLB proper, in other words, no other overlapping dementias, the cognitive issues are less about memory and much more about executive functioning challenges like reasoning, problem solving, and fluctuations in alertness. My mom, for example, never exhibited memory loss so much as extreme confusion in terms of where the memories fit into a timeline. She would insert people and events into the wrong chronological place, but her short and long-term memories were fairly well preserved even in the later stages of her decline. REM sleep behavior disorder is very common in patients with DLB, so much so that it is considered a core clinical feature. This does not mean that if you or someone you know has REM sleep behavior disorder, they also have DLB. Rather, this means it is one of the common features of DLB. REM sleep behavior disorder is not as common in Alzheimer's disease. As far as recognition and awareness, DLB patients are often able to recognize people and faces up until the moment they die. whereas Alzheimer's is characterized by increases in loss of recognition over time. So if a patient with DLB has no other overlapping types of dementia, then there is a good chance they will never forget who their loved ones are. Hallucinations, particularly visual hallucinations, are extremely common in DLB patients, with approximately 80% experiencing visual hallucinations early in the disease process. Hallucinations are sometimes the first symptom that DLB patients experience, and they can fluctuate in frequency and severity as the disease progresses. With Alzheimer's, hallucinations early in the disease are much less common, but in the later stages, approximately 20% of Alzheimer's patients can experience hallucinations. As far as movement, DLB patients can experience specific challenges. Muscle rigidity, stiffness, tremors, and falls are common. These movement symptoms can ebb and flow the same way the mental symptoms can. Alzheimer's patients do not characteristically have disease-specific movement challenges like DLB, but as any dementia advances, spatial awareness can potentially become compromised, which can lead to movement problems. Finally, smell is an important symptom to discuss. Loss of smell or reduced smell is very often the first symptom in Lewy body disease. This was my mom's first symptom, and it preceded any other symptoms she had by at least 5 years. In Alzheimer's, loss of smell is not as characteristic as it is in DLB and Parkinson's. So we just saw how DLB and Alzheimer's are different, but there is also the possibility that someone may have mixed dementias. And interestingly, DLB and Alzheimer's in particular seem to overlap frequently. Specifically, as many as 50 to 70% of patients diagnosed with DLB while living meet Alzheimer's consensus criteria upon autopsy. And similarly, approximately 50% of patients diagnosed with Alzheimer's while living show Lewy body pathology upon autopsy. So, how is DLB diagnosed? A DLB diagnosis is made by looking at two main things: clinical features and indicative biomarkers. On this slide, you will see two types of clinical features: core clinical features and supportive features. And I'll give you a moment to take a look at these before we go to the next slide. The second factor involved in DLB diagnosis are indicative biomarkers, which are displayed here per the 2017 DLB Consortium guidelines, which are the most recently updated guidelines that we have. None of these tests alone are definitive enough to make a diagnosis with 100% accuracy, but when used in combination with a clinical exam, consideration of core clinical features, and patient history, these biomarkers can aid in diagnosis. So putting together what we saw on the two prior slides, a DLB diagnosis is considered probable if two or more clinical features of DLB are present, with or without the presence of indicative biomarkers, or one core clinical feature is present with one or more indicative biomarkers. There are two diagnostic tests that have become available in very recent years that are remarkably accurate at diagnosing the presence of alpha-synuclein in nerve fibers. The first is a skin biopsy test called SYN1 that was created by CND Life Sciences. SYN1 was able to detect alpha-synuclein in 96% of DLB patients, and importantly, some of these patients were in the early stages of the disease. The test is minimally invasive. It is a tiny skin biopsy in 3 specific sites. The test is covered by Medicare, and the SYN1 website provides a patient access team with an email address and telephone number listed on this slide if people need to contact them to have their out-of-pocket costs potentially reduced. If you or someone you know is interested in having this test done, there are several academic centers that perform this test, a local one to the Triangle being UNC Neurology. But if you live far away from an academic center, you can ask your primary care doctor if they would be willing to do this biopsy. And if so, you or your doctor can order a testing kit directly from C&D Life Sciences. The company provides training videos for whoever will be doing the biopsy. So if geography is limiting someone from getting this done, it's worth asking if their local doctor is willing to perform this test. Another test that is fairly reliable in terms of accuracy is called the Syntaps cerebrospinal fluid test. This test is more invasive than the skin biopsy because it involves a lumbar puncture, and it's currently not covered by Medicare. So how is DLB treated? There are some pharmacologic interventions that may help, specifically with cognition, movement, and mitigating psychosis. The generic name of these medications is listed in the middle column, and the brand name is listed on the right. Importantly, this list is not all-inclusive. Please note the first three medications on this slide listed under the brand names Aricept, Exelon, and Razidine. These are cholinesterase inhibitors, which are considered the #1 treatment to improve cognitive impairment. Cholinesterase inhibitors assist in breaking down acetylcholine. This assistance in breaking down acetylcholine helps DLB patients since they often exhibit significant decreases in cholinergic function. There are also quite a few medications that may cause harm and should be avoided if possible. And again, this list is not all-inclusive. I would like to highlight a few things on this slide. First, haloperidol, which is sometimes shortened to Haldol, is frequently administered in emergency situations to help calm a person down. EMS gives haloperidol frequently, as do emergency room personnel. However, in DLB patients, haloperidol can cause severe reactions, so it is important to list this medication as an allergy, even if a DLB patient has never actually been administered it. I had haloperidol written as an allergy on my mom's medical bracelet, and the ER still tried to give it to her on several occasions. So it is really important to try and stay on top of what medications are being administered to your loved one in emergency situations. Second, an over-the-counter ingredient that can potentially cause great harm to DLB patients is called diphenhydramine. This is the main ingredient in Benadryl, as well as other over-the-counter medications used to treat cold, cough, and flu symptoms. So if you or your loved one is diagnosed with DLB, always look for diphenhydramine in the ingredient list and avoid any medications that contain it. Third, many antipsychotics should be avoided in DLB as they can cause extreme reactions such as worsening confusion, heavy sedation, and increased Parkinson's symptoms. Haloperidol, which I mentioned a few moments ago, is one example of an antipsychotic that should be avoided. Generally speaking, pharmaceuticals can do really strange and unexpected things in people with dementia, but particularly in patients with DLB. So it is really important to check with your doctor before taking anything new or changing the dose of a medication that you're already taking. Finally, anesthesia can cause complications in patients with DLB. So if a surgery is ever needed, be sure to talk to your doctor ahead of time about you or your loved one's DLB diagnosis. There are some non-medication interventions that have been researched in recent years. Diet is a big one and something that we can actually control. The MIND diet, which emphasizes the foods listed here, is a really proactive way of keeping our bodies functioning optimally. Also, avoiding ultra-processed foods is another way that we can try to stay healthy and give ourselves the best option to fight off disease. Altering diet is not a guaranteed way of preventing DLB so much as a way of optimizing cognition. My mom, for example, followed the MIND diet unintentionally her whole life, and she still died of DLB. But perhaps her cognitive symptoms would have been way worse if she hadn't taken such good care of herself. There's really no way to know for sure. So I don't want to build false hope, but I think it is worth trying the things that we have control over, and diet is definitely something we can control. There is also some really compelling research into the mind diet with studies that have tracked people's cognition over time and have found measurable evidence that this diet enables cognitive resilience. There are also some social, movement, and hobby related interventions that may be therapeutic. Exercise, particularly exercise that encourages repetitive movements, is beneficial. Speech and occupational therapies can help. Outdoor activities when the weather is nice, as well as games, music, and art. Basically, what you love and what makes you happy is really important for mental well being. With DLB, routines are particularly crucial for functioning. So, finding ways to establish routines and sticking to them can make the journey a bit more manageable. I added a quote about music to this slide because I feel like it captures how something as seemingly simple as a melody can greatly impact our emotions, mood, and consequent brain neurology. Next, I'll go over some resources for patients and caregivers. Support groups and educational opportunities are an excellent way for patients and caregivers to connect with others experiencing similar challenges. One local support group I highly recommend for caregivers is run by Pat Snyder, who many of you may know, and I think she may even be on this call today. Pat lost her husband to DLB and has devoted the years following his death to helping others get through this difficult journey, and in particular, caregivers. Pat runs a Wake Forest Dementia Caregiver class, which is offered in person and via Zoom monthly. If you want to be a part of this group, you can email Pat at the email address listed on this slide, and she will add you to the group mailing list. She also moderates a support group called LBD Caring Spouses. And Pat wrote a wonderful book called Treasures in the Darkness, which is very inspirational and positive, particularly if you're dealing with the early stages of DLB. The Duke Dementia Family Support Program is a fantastic resource that is not limited to Duke affiliated individuals. They have numerous services that are education, support, and caregiving related. They do wonderful work, and their website is listed here at the bottom of this slide. Family caregivers may be interested in participating in a study called Persevere, which is funded by the National Institutes of Health. Persevere is interested in learning if a caregiver centered educational intervention can improve caregivers' knowledge, confidence, strain, and health outcomes. And in turn, they are hoping this will help DLB patients. All participation is virtual and there are no in person visits. More information about Persevere is available via the link at the bottom of this slide. There are numerous dementia organizations that have tremendous resources. I would first like to highlight the Lewy Body Dementia Association, or LBDA. They have a large assortment of articles, care summaries for patients, caregivers, health professionals, and donors. They also have a 24-hour caregiver link, or Lewy helpline, which I personally used on more than one occasion when I was caring for my mom. Each time I called, I was connected to a social worker or a healthcare professional, and they helped talk me through my concerns. A couple of things that I would like to highlight on the LBDA website. The first is a downloadable medical alert card, which is something of potentially great value, particularly if your loved one is ever in a situation where they are alone. This medical alert card lists emergency contacts as well as provides warning for health professionals who may not be familiar with the dangers of antipsychotic medications in DLB. The second thing is a downloadable link to the Diamond Lewy Management Toolkit, which is specifically designed for clinicians, but I'm calling it to your attention in case patients or their caregivers may want to bring it with them to doctor's appointments. Some doctors are more knowledgeable about DLB than others, so it can be helpful for physicians who know less about DLB to see some of the management guidelines in writing. The LBDA has several research centers of excellence around the country, and one of them is here locally at UNC. Dr. Andrea Bazzoki, who I contract with on some local initiatives, is the principal investigator for the UNC LBDA Research Center of Excellence. Dr. Bazzoki is a neurologist and a tremendous advocate for those with DLB as well as other dementias. In October of last year, the LBDA and the Food and Drug Administration held a joint initiative where patients and caregivers chosen from a representative sample shared their personal experiences with DLB and offered their hopes for the future of DLB drug development. I was fortunate to be one of the panelists and was humbled by the stories that people had the courage to share. If you are interested in watching some or all of this informational event, the link is available on this slide and can be accessed through YouTube or the LBDA website. The North Carolina Registry for Brain Health is also a wonderful resource. They partner with various North Carolina-based academic institutions that are listed on this slide. Through their website, people can enroll and learn about participatory brain disorder-related research studies. The primary goal of this registry is to expand our understanding of brain health and bring participatory research projects into the community. The Dementia Alliance of North Carolina is a fantastic organization that everyone attending today is likely very familiar with. As you know, the Dementia Alliance provides caregiver and patient support information, dementia education, research, outreach, and local events. Another local research initiative is the Duke UNC Alzheimer's Disease Research Center, or ADRC, which is a collaboration between researchers, physicians, staff, and patients in Eastern North Carolina. The ADRC focuses on identifying early and midlife factors that may be contributing to Alzheimer's and related dementias. If anyone you know is interested in getting involved in research with the ADRC, they can join the Alzheimer's Disease Discoveries in Medicine roster, or ADME, and will be contacted about participating in related research clinical trials. A QR code can be found on this slide as well as the webpage link. The Alzheimer's Association also has excellent material, and even though Alzheimer's is different from DLB, many of their resources are applicable to handling dementia-related challenges, particularly for those people dealing with overlapping dementias or co-pathologies. They also have a 24-hour helpline for people seeking disease management advice. The final organization I want to highlight today is the Brain Support Network. Their website has links to national and international support groups for DLB and other brain-related disorders, as well as links to many educational resources. If someone you know is considering brain donation, they can arrange this for you. The Brain Support Network helped me donate my mom's brain. Many years before she died, my mom had signed all the paperwork to have her body donated to medical research, as my dad and grandmother had done. But because mom ended up weighing so little towards the end of her life, no organization would accept her donation. My mom was a professor her whole life, a huge advocate of continuing education, and a person who dedicated her life to others. So the thought of her years of suffering not being able to help someone else was something I found really difficult to accept. So I began searching for an alternative to body donation, and I was fortunate to find the Brain Support Network. They arranged for my mom's brain to be donated and, importantly, placed directly into the hands of Lewy body researchers. I realize that talking about brain donation is a difficult topic, but at least for me, there was something quite beautiful about the process in that it gave my mom the opportunity to continue to help others and to continue to teach infinitely. The Brain Support Network also provides a full pathology report to the loved ones of the person who donated. This pathology report meant more to me than I realized it would, because it confirmed my mom had full diffuse dementia with Lewy bodies. Mom was never diagnosed with DLB while she was living. She was misdiagnosed with Parkinson's disease, although I always suspected DLB. So seeing the correct diagnosis in writing actually provided some relief to finally have an explanation for so many seemingly inexplicable things that we had been through together. In the next section, I will briefly touch on managing the everyday challenges associated with DLB. This section is primarily directed towards caregivers, but since many of you in attendance today are support group leaders or ambassadors who frequently encounter patients and their families, I wanted to share some of these thoughts in case anything might be helpful in your support groups or advocacy work. Due to hallucinations, delusions, and cognitive changes, DLB can cause fluctuating levels of alertness, attention, and mood. These changes can be sudden, they can last minutes or hours or days. One of the most challenging things for me was not knowing what to expect on a day-to-day basis. So the suggestions on this slide definitely fall into the category of easier said than done. I am by no means saying these things are simple to do, particularly when you're in the throes of caring for someone, but they're things to keep in the back of your mind and to try whenever possible. The first suggestion is to try to remain calm. If you can stay calm, then there's a chance that the patient will not be as agitated as they may be otherwise. Alongside this, try to talk slowly and reassuringly. Try to not take things personally. Recognize that when hurtful things are said or violent behaviors are exhibited, it is the dementia at play and not the person you are taking care of. Next, always reassure the patient of their safety. Some patients cannot express their fears due to loss of language or confusion or both. So even if they are not verbally saying they are scared, there is a chance that they are frightened. The unknown in and of itself creates a sense of fear. And then coupling this with the fact that most DLB patients are usually able to maintain their awareness. It must be terrifying to be aware enough to know that your mind is not working the way you want it to. So at any time, a patient can be reassured that they're physically safe, you are safe, and you care for them or you love them. Sometimes this is all someone needs to feel some peace. Distractions can sometimes help and sometimes they don't. There were times when distractions got me through the day with mom, and other times they did nothing to ease her mind. You have to keep trying. You never know what strategy will work one day and not the next, or vice versa. You have to remain resilient and keep trying new things. Finally, Dr. Coffer, who some of you may remember, was a wonderful neurologist who specialized in taking care of patients with DLB as well as frontotemporal dementia. Sadly, he passed away suddenly from cancer several years ago. He was once asked for his advice on how to interact with dementia patients, and he replied, "Honor who they are." I think what Dr. Coffer was saying was that no matter how far advanced a person's dementia may be, the person that existed before the dementia is still in there somewhere, and they likely do not want this diagnosis to define them. If you can find ways to reach that person, respect that person, and make them feel your value, then you are honoring them, which is a beautiful gift. This slide is a simple reminder that sometimes the little things are big things and they can help you get through the day. If you're a caregiver, try to schedule breaks, even if they are small and even if you don't think you need them. A few minutes to clear your head can make all the difference in the world. Next, find someone to talk to. It could be a professional person like a counselor, or it could just be a friend. But having someone to talk to and share your day-to-day experiences is invaluable for your mental health. Try to get outside. Just breathing some fresh air can sometimes reset your mind. Be kind to yourself. Accept that you will make mistakes. Remain cognizant that everyone is functioning under extremely difficult circumstances. So there's a level of empathy that needs to be brought to the room, and everyone in the room is in need of receiving that empathy, including the caregiver. Focus on what you can control. The unexpected is one of the hardest things to manage in life, but particularly in a condition like DLB, where symptoms fluctuate from minute to minute at times. I never knew what to expect when I went to mom's house, and I developed some anxiety strictly because there was no predictability to anything. Next, ask for help. Recognize that what you are doing is incredibly hard, and you can likely do an even better job if you ask for help. And finally, if you are able, do what brings you joy. There are some books that are incredibly helpful, and a few are listed here on this slide. I'll give you a moment to look at those. There are a few clinical trials for DLB. If you're interested in looking at what they are, the best way to see the active ones is to go to the LBDA trial tracker or the clinical studies link that's also on their website. So both of these links are here on this slide. These are my references. And that brings us to the end. I hope this presentation was helpful, and I'm happy to take questions or we can have an open discussion. So I turn it back over to our hosts.
Thank you very much, Erin. That was so informative, so much information. Will you share your slides with us so I can send them out to everyone? Okay. And
Absolutely.
also, great. And also, because we all want those resources that you shared.
Yes,
Also, we will be sending out your contact information to
that's fine.
everyone, but are you okay if people reach out to you either with
Yes,
questions or since we do have so many support group leaders, someone may be interested in having you present to their support group as well.
I would love to do that. Yes.
All right. Well, if anybody has any questions that they want to ask, if you go down to the reactions button, you can raise your hand and that will help me know who has a question, or you can type your questions in the chat. Either way, whatever's easiest for you. Betty? Everybody's
See,
processing the information.
oh, one person put their hand up.
Oh, Ramsey, hi. Yeah, you can go ahead and
Hi,
unmute.
thank you.
Hi.
Hi there. My father has Parkinson's of the Lewy body. So, and it was diagnosed that way with the other one. I wanted to ask you if you've learned anything about what I hear is called the Lewy lean, where someone, yes, because I work in a senior center and I see it. And I don't want to diagnose anybody, but I was curious if you had, I just read about it recently.
Yeah, so that was my mom's first physical symptom. Um, she had the mental symptoms first, but in terms of physical changes, she never had like the tremors or anything like that. She had a very extreme Lewy lean, and um, it's also called Pisa syndrome. It's kind of a terrible analogy, but like the Leaning Tower of Pisa, it's often referred to as Pisa syndrome. So, my understanding is that, like, if this is your torso, um, people can lean at the waist. So the waist down is straight, but then their upper body leans this way, sometimes forward, but it's usually to the left or the right. Um, this is strictly something I observed. This is not scientifically proven, although some articles I've read have showed similar statistics supporting this. But with my mom, her lean would get more severe a day or two before she would have a significant um, mental lapse. I This was before I truly understood what was happening. So I didn't know what to do other than keep taking her to her doctor, and her primary care had never seen it before. They had no idea. So I started just taking notes, and I had a whole journal of notes. And that was one of the only patterns I ever found, was that the lean would get significantly worse before she had um, a significant mental decline. Again, it was just an observation, but yes, it's very common in dementia with Lewy body patients. I'm not sure if it's as common in Parkinson's, but I would imagine it might be.
Could
Is there,
be. Yeah. Yeah. Dad's
Is
got
it-
a forward lean, the man in the barrel. Yeah.
Yes.
But yes.
Yeah, and at least with my mom, she was completely unaware. She thought she was straight up and down. So the first time it happened, I thought she'd had a stroke. And, you know, I took her immediately to urgent care. I did the amateur stroke test, like on the way to the hospital. I'm like, speak to me, look at me. There was no facial droop. She was squeezing with both hands. I mean, there was none of the signs of a stroke were there, but I thought, well, why else would she just be slumped over? And urgent care was as confused. They sent her to the ER. They were completely confused. They kept saying, do you not feel yourself leaning? She's like, what are you talking about? You know, she thought, so it's super disorienting to the person, but it's also, as one would imagine, a tremendous fall risk.
Thank you.
Yeah.
Thank you. I think Sanjay, I think you have a question. You want to unmute?
Yeah, thanks for taking my question. First of all, that was phenomenal. There was a lot of information to process, and I'm not even a caregiver. I work in this field, but that was a tremendous amount of information from different angles. So I'm very, very, very thorough. Thank you for sharing that.
Thank
So
you.
in hindsight, no, you're welcome. Very welcome. So hindsight, what would you do today? You know, if somebody's going through a similar kind of scenario, because every situation is different, so there's no cookie cutter approach, right? For somebody with LBD, depending on the scenarios, how would you approach it? What would you tell people to do or not do, you know, initially and throughout their kind of areas? Because some people are not able to take care of them at home. So it's just kind of coincidental. The first gentleman we were asked to help had Lewy body. That was 11 and a half years ago. I had no clue what the heck I was doing, right? I didn't even know what to do, how to support, how to help this couple. And the lady placed him in a memory care place, and it was a terrible experience overall, right? So in hindsight, what would you do for somebody in that kind of situation?
So do you mean once someone has a diagnosis or before?
And further along, no, further along. I mean, before there's not, you know, I mean, we do what we do. I mean, you know, just like having, I don't know if I have this disease or not. I mean, I don't really care until something happens, you know, etc. But I'm talking about after his diagnosis, after you know it's going to go downhill or it is going downhill, when you're not able to take care of that person by, you know, at home, or some version there. What do you do? You know, how do you handle kind of scenarios like that?
I think it's one of the more difficult questions, and there's no really good answer. But what I ended up doing with my mom, I mean, I've always worked full time, and I had 2 babies at home. She couldn't be left alone for a minute, and she lived 2 blocks from us. I knew that moving her to a home, assisted living, and we even tried moving her in with us, made her much more disoriented. Um, she had lived in this home for 50 years. My dad died 20 years ago. They had a magical relationship. All of her memories of him were in that home. So I told my husband, and I sat down and talked, and I said, we have to try to do everything we can to keep her in that home. So I ended up hiring 24-hour care. I mean, I was there all the time, every day. I worked from her house. But she could not, you couldn't leave to go use the bathroom, because she would try to, you know, she'd be having a delusion and she'd try to crawl out the front door, or she'd fall, or she'd try to, you know, just, so she had 24-hour care the last 2 years of her life. And I have a list of organizations that, you know, I give people to try to get in-home care if they can. I recognize the cost is incredibly prohibitive. We could not have done it for much longer. So unfortunately, people usually end up sending people to a home, and I'm not saying that's a bad thing. I'm just saying my hope going forward is that some of the care homes can be better educated on what this particular type of dementia is, and all the dementias, the importance of recognizing that all dementia is not the same. And just because someone's getting old does not mean you should expect to get dementia. It's not a normal part of aging. The more we learn about the different types and educate the people that are caring for these people about it, the more I'm hopeful that the care situation in some of these homes might get better. I feel like dementia with Lewy bodies is particularly challenging because of the up and the down. Yes, every dementia has its ups and downs, but it's startling, particularly in like the early to middle advancement stages of the disease. My mom, at least, would go from 100% being herself in personality, in her gestures, in the way she talked, in the engagement with her eyes. And then it was like somebody just dropped something over her face and she'd just be in a trance. And when it first started, it was second to second. It became longer and longer. So I can imagine if I was working in a home and I had a patient like this, I would be so confused. I wouldn't know what to do. So this is not really the best way of answering your question, but I think I would try to tell people, in however it can be phrased, in a gentle and kind way, like if this person lives long enough, you can't do this yourself as a caregiver. You're going to need help. So start looking at finances, start thinking of best case scenario, worst case scenario. There are some group homes that I've heard really good things about, that they take it's like one nurse per like 6 people. It's harder to get into those. But the sad part is that a lot of the bigger nursing homes, if they see a DLB diagnosis, they won't take people. So thank you for raising this important point. I don't know what the answer is, but I hope there's a way a support network can be better developed for these patients and their families.
Yeah, no,
So thank you both so much. I'm sorry to cut you off. We do have one more question, but really quickly, I'm going to ask Dee Dee to unmute because I know she wants to share about the support group that we have as well.
Yeah, and Erin, thank you. This was amazing. So thank you.
I'm so glad.
Yeah, I know Pat Snyder is on here, and you definitely, we love Pat and all the work she's doing. I did want to mention, in case anybody on here is not aware of, we also have another LBD support group with folks right on this. Lori Idle's done it for years, and now Beverly Rogers is the lead of that. So it's on our website. It's under Wake County, but it is an online group, so it can be open to anybody across the state. So I just wanted to recognize that we do have that one. Besides Pat's, we do have another group that is specialized just for Lewy body caregivers. So want to make sure everybody knew about that.
Thank you, Dee Dee. We appreciate that. I think we have one more question, and we're going to go to Ashley Keaton. Ashley, if you want to unmute.
Hey, thanks. I know we're running up on time. Erin, thanks
okay.
for sharing your personal story. I definitely think that actually makes a difference in these conversations or presentations. But I'm going back and forth here with the Lewy body thing. Like we don't, my mom does not have a medical diagnosis, but early on when this whole thing started and I started reading, for whatever, you know, unmedical, non-medical reasoning or education myself said, I think she has Lewy body. But I don't, nobody has ever told me that I'm accurate or not. A lot of the things you said today made me think, yes, that's true. One of the things you just said a few minutes ago made me start to question it again. When you said like one day your mom was perfectly herself and the next day not. I don't think we have any days that I feel like my mom is perfectly herself. But there's a lot of other things that you have pointed out that definitely are her. But I guess my question to all that is, does it, and I don't mean this to sound insensitive. I like to think of myself as just a realist.
Yes.
Does it really matter? Like, what would I gain by going and finding some medical professional tell me, yes, you're right or wrong? Because from what I can tell, it's not going to change the outcome ultimately. So I guess that's my biggest question. Do we, we have been to a couple of neurologists, and really all I've done is given her the whole like, what date is it, who's the president kind of thing, and we go home, right?
Yeah.
And I'm okay with that because I unfortunately don't think we have any answers to this yet, or really medications or any therapies. Um, so that's but I don't know if I should continue to pursue the answer to this or just assume that I'm right
I
and then go
totally
on.
understand.
Yeah.
No, and this is a really important question. I think the brief answer is yes, you should pursue it for two main reasons, as long as your mom can tolerate it. The first is it would be helpful to know if she has it, so you know if she's particularly sensitive to any of those medications that are
That would,
dangerous, and
yeah.
also so she could potentially go on the cholinesterase inhibitors. So
Okay.
my mom was not correctly diagnosed. She was treated for Parkinson's, and the medications that she was being given for Parkinson's potentially made her cognition worse.
Okay.
If I had known and it had been proven that she had DLB while she was living, those medications would likely have been altered or withdrawn, and they would have been replaced with the cholinesterase inhibitors. The test that is available now that was not available when my mom was living, or at least it wasn't well known, is the SIN1 test. And that test would not tell you if your mom had Lewy body, but it would tell if she had the alpha synuclein excess in nerve fibers. That test plus a clinical exam by a good neurologist, I highly recommend Andrea Bazzoki at UNC, would almost definitively make the diagnosis. That was not an option when my mom was living.
Okay. I did, when you mentioned those medicines, that is one thing that I thought, okay, maybe I need to pay attention to this. Yeah, I mean, like with the Benadryl, I thought, God, I mean, how many times do people hand somebody Benadryl?
Correct.
And okay, but
If
and
you
her
send me your mom's
Mhm.
name
Okay,
or your contact information, if she's
okay,
not already a UNC patient,
okay,
I can send Dr. Bazzoki a note,
okay,
because the
perfect.
biggest hurdle right now is people outside of UNC can't get through the initial screening to
Mhm.
get in to see her, and that's out of her control. So we're trying to find a route around.
Yeah, okay, perfect. Yeah, and the thing I think that's the most, I guess, hard to watch for my mom is the awareness. Like my sister and I've said it the
Correct.
whole time. This thing is so weird because while we know she has something, dementia, whatever, she's also it's hard to watch because she's so aware of it. She knows she
Yes.
has it. She knows something is wrong.
And based
She
on that
says it.
alone,
Yeah,
I would, I
wild.
mean, I'm not trying to play amateur
Yeah,
doctor by
yeah, no,
any
I know.
means, but
Yeah, it's weird.
there were many moments where I wished my mom was just in a
I've
complete, utter bliss of cluelessness. She
Me
never
too.
was.
I've said many times, I wish she would just get to the point where she doesn't know who any of us are, who she is, because that seems easier than the
Yeah.
state we're in right now. And I feel guilty saying that, but I mean, I do, because she's in this horrible state of turmoil because of the awareness. So
It's
yeah,
it's
yeah,
the cruelest form of mental torture.
it is. Yeah, yeah.
I'm
Thank
so
you.
Great. Well,
sorry you're going through
Thank,
this.
thank you.
we're-
Thank you.
thank you for sharing that, Ashley. I know that's difficult when you're brave to talk about it in front of everybody, but it helps all of us understand the situation as well, and to be more empathetic to the groups that we're working with, the families that we're working with, and our own families that are experiencing this too. So thank you all so much for joining us today. We will share this recording. We will share all the resources and slides with you. I dropped some additional information in the chat, but if you have other topics you'd like us to talk about, questions, anything at all, please don't hesitate to reach out to Dementia Alliance, and we will share Erin's information with you too. So if you want to connect with her directly, you can do that. Erin, thank you so much for your time today. We greatly appreciate the information. I think we all learned something today.
I
So
did too,
thanks
so
so
thank
much.
you.
Good, good. Thank you
Yeah.
all very much, and have a great afternoon.
Okay. Take care. Bye, everyone.